Start. Hello, good evening, everyone. Welcome to today's grand round. Today, it is going to be an interactive session as it is the crash course on red eye. All of you will be involved as we used to see this case very often. It is moderated by Dr. Harita ma'am and will be presented by Dr. Divya Shankar. Today on panel, we have Dr. Heel, who is a cornea fellow in Shankara, Dr. Shaiza, who is a cornea fellow, and Dr. Shushmita, who is a third year primary DNB resident. From now onwards, Dr. Divya Shankar will take over and will brief you with the cases on red eye. Thank you. Over to you, ma'am.
Good evening, everyone. So we have put together this grand rounds as an exercise in clinical ophthalmology. So imagine that you are sitting in the general OPD and you face these cases. We want to refine your thought process as you see these cases and how you decide how to go forward with them. So I shall warn you now itself, this is an image-based quiz. And I will put up pictures and we will come up with differential diagnosis based on whatever history and clinical findings that we can see. And then we will very briefly discuss only those relevant points related to that particular topic. So we will be running through a variety of topics and we will not be focusing very deeply into any one particular topic. And so I will be picking your brains and asking questions at every point throughout this presentation. Not to panic. Correct answers shall be rewarded with dairy milk. And those who collect the maximum number of dairy milk at the end of the day shall get another trophy of sorts. So there will be no judgment, no fear. We want to hear your thought processes. We want to hear your differential diagnosis, and we want to hash it out with you today, right? And differential diagnoses are welcome, but please write your questions in a piece of paper and keep them so that we can discuss them at the end of the presentation, right? Because we cannot end up fixating on any one particular topic. So shall we begin? Okay. So how does an eye become red? It's very simple. Either there's a direct bleed, so it could be a hemorrhage, or there is some inflammation leading to dilatation of the blood vessels, and that presents as dilated tortuous vessels with adjoining edema, or structurally itself, the vessel is abnormal. So vascular abnormalities will also present as red eye. Now, not exclusive to these two, but very commonly, these are the forms of red eye that we see. Can be a conjunctival congestion or a circumcorneal congestion. Now, first question for chocolate. Please tell me the differences. Primary DNBs. Juniors, please. Please don't hesitate. Please be quick about it. We have a lot to go through. Please, someone very simple. The difference. Yes. Yes. How do you make out the difference? What are the points in favor of each?
More in the fornices and generalized.
Yes, more in the fornices. Do not get confused by this one. This is his limbal pigmentation. So ignore that. So this is more of a corneal congestion. This is more of a around the cornea. Which is centrifugal, which is centripetal? Centrifugal would mean towards the center. Centrifugal is towards the center. From fornix towards the center would be a conjunctival congestion. And that from limbus towards the fornix would be a centripetal, which is circumcorneal congestion, right? Chocolate for Vipin and Manjot, please. Right? Also, this is very bright red in color. This will have a bluish hue, right? I'm going to start with my first case. So there is a 33-year-old adult male presenting with acute onset redness, itching, watering in his left eye since 5 days. He is not giving any history of trauma. I took a picture. It's simply the first picture that I put for conjunctival congestion, right? Now we zoom in on his cornea. What do we see? SPKs, right? So together with this congestion and with these SPKs, we come to a provisional diagnosis of acute conjunctivitis. It's very simple. Now, many of these questions have very simple answers. Some of these images don't have so obvious answers. So initially it will be quite deceiving for you. This is a simple case of acute conjunctivitis. Okay. So now the point I want to discuss here is we have a case of conjunctival congestion with SPKs. If it is an infectivity, it can be what viral? Adenoviral, yes. Okay, that is only adenoviral. Na? Specifically, herpetic can be confusing, yes. Another one looks very similar to this, microsporidiosis, right? So we have to differentiate between these three because the treatment for each is very different, right? So I will start with these adenoviral, or rather these are SEKs, which are under the epithelium. They are broad and they have a very non-specific distribution, and they generally will not take up stain. Maybe in the acute stages, they may faintly take up stain. These respond very well with steroids. Now over to our panelist. Can one of you please tell us what are the strains of adenovirus and what are their manifestations?
Adenovirus is usually a double-stranded DNA virus. There are around 49 serotypes, which has subgrouped into 6 subtypes, A to F. And there are 3 different types of conjunctivitis manifestations regarding adenovirus. First one is acute follicular, which is non-specific serotypes. And second one is pharyngoconjunctival fever. The serotypes will be 3, 4, and 7, where there will be conjunctivitis along with pharynx involvement and lymph node involvement. And the third one is epidemic keratitis. The serotypes will be 8, 19, and 37. The serotypes involved epidemic keratoconjunctivitis are resistant to most of the disinfectants and also to the external environment. So this type of when there is an epidemic, the disinfectants which we are using in routine, such as alcohol swabs, are also resistant to them. So we have to use sodium hydrochloride solutions for the disinfection. And mostly we have to go for non-contact procedures during this epidemics.
So as she said, adenovirus has 3 common manifestations. First being a normal acute conjunctivitis. Second one is pharyngoconjunctival fever. And the third one is EKC, which is epidemic keratoconjunctivitis, right? And as she said, the adenovirus is very resistant to most of the disinfectants that we use versus the herpes virus, the HIV virus, which is quite susceptible to these disinfectants. Can you tell me why? Adenovirus is scarier than, yes, it is which one is enveloped? If you have an envelope, you have something to lyse. So it has to be the herpes and the HIV virus which have envelopes, which means you can lyse it with the disinfectants, while adenovirus is a non-enveloped virus and therefore it has other defense mechanisms. So just cleaning with an alcohol swab on your tonometer tip is not enough. We have to use a sodium hypochlorite solution, right? Now, this picture over here is showing a high magnification picture of sclerotic scatter, right? This is basically a non-specific situation, but I've taken it from a journal. These are the herpetic vesicles. We all know that herpes presents on the skin with vesicles. Similarly, on the epithelium also, it starts as vesicles, right? So the virus enters the cell, replicates, then the cell becomes cytopathic and devitalized. So these will become vesicles, and then when they rupture, they will take stain, right? That area the cell sloughs off and takes stain. So this is a picture of the herpetic SPKs, but these will last only for a few hours. They won't even cross more than 24 hours. So most likely we will not see this presentation. They would have become a dendrite by the time we see them. So it is very unlikely that you see herpetic SPKs, but you have to keep it in mind. And the third one here, can someone describe it, please? Very easy, please. Stuck on appearance, greasy, discrete, raised, right? So that is typical of microsporidial. A microsporidiosis initially was classified under protozoa. Now, from molecular biology, it is reclassified as a fungus, and it is an obligate intracellular parasite, which would mean that, what would that mean? That would mean that just taking a scraping and putting it on our routine blood agar, chocolate agar is not going to work. If we want a culture, we have to put it in cellular media only, but it is very easily seen through a gram stain, and it is gram positive as seen here. These purple colored bodies, right? Usually there will be some supporting history. There will be contact with contaminated water, history of swimming in a pool or a river, or it is common in the rainy season, or history of contact lens use may or may not be elicited from the patient, but this can support your diagnosis. Now, the picture that I have shown you was the epithelial form or the SPKs, right? There are two forms. One is these SPKs and the other one is the stromal form. The stromal form looks very much like fungal keratitis, and the classic teaching says that the epithelial form is seen more in immunocompromised patients. So they may be HIV positive, they may be having some underlying malignancy, etc. So the textbooks say it would be a good idea to investigate those patients who present with microsporidial SPKs for any immunocompromised status. But nowadays, more in Southeast Asia, like India and Singapore, this form is also seen in immunocompetent individuals as well. So we would diagnose it by taking a swab and putting it under this microscope, and we would see those classic gram-positive bodies. But do we scrape on the first visit is the question. So we do not scrape all SPKs on the first visit unless and until it looks very pathognomonic. And that will also be only for a diagnostic purpose. Therapeutically, scraping off the SPKs will not change the outcome for the patient. So scraping should be reserved only in those situations where you give treatment and it is not responding at all. Coming to the second case, we have an elderly, a 56-year-old female, long-standing 1 month history of redness and discharge in the right eye. So here you can see, here you can see this localized conjunctival congestion here. We can see bits of discharge, right? And we can see here a healed scar, which was probably an old microbial keratitis. Now, if this patient came to you with the OPD, what would you want to look for next?
So we need to check for Roplas.
Yes, Roplas was negative. You want to diagnose the underlying pathology here. Like I'm asking you examination on the slit lamp. Valid, but no foreign body. What are you looking for? But why would that cause in a 56-year-old lady? How likely is that? So she was very close when checking the blast. You have to check the list. Who said that? Why should one diary milk goes to her? This was a case of canaliculitis. So can you see the tarsal congestion over here? And does that punctum look normal to you? Yes, no? What does a punctum look like? For reference, this is a normal punctum. Does that look edematous? Does that look pouting? So pouting punctum is very pathognomonic of canaliculitis. So we have to treat this patient how? By expressing it out or else by. But how long can you express out? What is a definitive treatment? 3-snip procedure. You have to do 3-snip. We did madam did 3-snip. So in OT, this is what we found. Can see the granular mucoid material. 3-snip procedure was done and the patient has now recovered very well. So this was one case of chronic conjunctivitis wherein the underlying etiology was canaliculitis, right? I will show you another case of chronic redness. 57-year-old female, 5 months history of redness in the left eye since 5-month history is there. This is the picture. There is some tortuous vessels, a little bit of chemosis. She's presenting in your OPD. You're allowed to ask her his questions. History of trauma is there. 6 months back, she fell in the bath. That is exactly right. In this patient, it was a low flow CCF, right? So we have these older women who present with some mild chemosis, mild congestion. You are giving steroids, you are giving anti-allergics. There's absolutely no response. There's history of some trivial trauma in the past, or CCF can also be spontaneous. So it should always be in the back of your mind, right? So any conjunctivitis which lasts more than 3 weeks is termed chronic conjunctivitis, right? And now we are going to, you saw a case of chronic conjunctivitis.
One question from Dr. Sajal Jain on YouTube. Is there a difference between SPK and PEK?
Punctate epithelial keratitis and superficial punctate keratitis.
What is the difference? Is there a difference?
No, they're just commonly used terms when it comes to these superficial lesions in the cornea. Many a times they are interchangeable. SPK is considered a subtype of PEK. Okay, so coming back to chronic conjunctivitis, you have a patient sitting in front of you, long standing history of redness, and you want to determine what could be the cause. In my MBBS time, we had to give etiology in any subject starting from medicine, opthal, ENT for any question, what is the etiology karke? Then I used to keep a mnemonic in my mind, which was VINT, V-I-N-T. So V for vascular, I for inflammatory or infectious, N for neoplasia, T for trauma. This would work almost for any question. Idiopathic, absolutely. So you can keep VINT in mind and give me an answer. So keeping VINT in mind, you have a chronic redness patient in your OPD. Tell me possibilities for B, vascular. We just saw it. CC, we just saw it. I for inflammatory or infectious. We're going to start with infectious. Long-term or long-standing chronic conjunctivitis. Give me positive organisms. Staph, okay. Associated with scarring, cicatrization. Chlamydia. Who said chlamydia? one chocolate for them. So chlamydia, right? One more. Associated with lymphadenopathy is an exclude. Acute. Adenoviral tends to be acute. Conjunctivitis is not so common. Associated with preauricular lymphadenopathy, submandibular lymphadenopathy. Patient has a pet cat. Paranoids. Who said paranoids? Please give them one. So that is paranoids oculoglandular syndrome, right? With cat scratch disease. The organism is, for one more dairy milk, Bartonella. Bartonella. Right. So I for infectious, inflammatory. Thyroiditis is beautiful. Yes. Somebody is collecting too many chocolates. Scleritis, I'm talking about chronic conjunctivitis. We have to think about scleritis, yes. But you have to give me differential diagnosis. We're talking about underlying etiology. Inflammatory. Rheumatoid arthritis, immunological diseases, they present with chronic redness, keratoconjunctivitis sicca. So that can present with this non-specific redness, irritation, right? N? Sorry? OSS and chronic redness, sure. Okay. Neoplasia.
This chronic, with the redness, with the water, with the you will not even assume that the person only has like
Coming to neoplasia, think oculoplasty. Sebaceous gland carcinoma not always presents as a mass. It can present in a pagetoid form. Patient might just be having chronic redness. So it should be in the back of your mind when your redness is not resolving. T? Trauma? What about trauma? Trauma causing dash. CCF, done. We're done with it. Sorry? Sorry? Trauma causing, again think oculoplasty. Muscle entrapment, why would it cause chronic congestion?
Entropy on any contact,
We have to come to contact lens, hold on. Trauma causing, what my point was, trauma causing chronic dacrocystitis. We have to check ROPLAS in those patients and if required, do a DCR for them, right? You can also include foreign bodies in the inflammatory part, yes. Some missed foreign body can lead to a long-term congestion. Very common foreign body that we prescribe. Sorry? Too many people have said that. I don't have that many chocolates. Contact lens, long-term history of contact lens leads to a chronic papillary reaction. So we may have to discontinue that or prescribe appropriate lubricants, right? So this is how much we have to think when we see a case of redness in the OPD. This is how much history we can elicit. We're still missing something.
in case of severe ectropy,
Lid abnormalities, structural abnormalities causing associated mechanical issues and redness, I agree. I have a history of surgery in the past. Suture. Common suture material causing chronic conjunctivitis. Vicryl. Okay. Then further, retina people, chronic redness in your department, exposed or extruded buccal, right? So these are things that we really have to look for. Okay. One more we have to think of in the inflammatory component. No, inflammatory in terms of allergy, that also we have to think of. Chronic conjunctivitis VKC, I shall accept. Allergy, drug allergy? Exactly. So, question for chocolate, pathognomonic feature of bromonidin allergy. Follicles where? Follicles, if in adenoviral conjunctivitis also there will be follicles. Microsporidial will have follicles. It becomes sago-grain appearance. Also, bulbar follicles. If the follicles are in the bulbar conjunctiva, a patient has history of using multiple AGM, you can almost always pinpoint it to bromonidin. Madam ki chocolate.
But I want to tell you one thing. Raised epithelial venous. So all the conditions like cerebral syndrome, the syndromes, which triggers the epithelial venous pressure. That will give the
Foxtrot.
appearance, and that is the definitive diagnosis for the raised epithelial venous pressure. Most of the patients, that are OCCF patients and the raised epithelial venous pressure, because of some other etiology. So those patients, they are present with that kind of findings.
So a little tip I learned very recently in Sudhakar sir's OPD was to compare the puncta, right? So we had a patient with some 2 weeks history of minimal irritation, watering only in the right eye. I looked at her, I examined her, lids were okay, everything was okay. I diagnosed her as a run of the mill lubricant addict. I gave her eye mist. Sir came, he had a look and he asked me to compare the puncta. And he told, and then when I saw, it was mild edema in the symptomatic eye and the other eye was normal. So it's these subtle findings which will help your patient. You may or may not have to start antibiotics, steroids, or anti-allergics based on these findings. So compare puncta. It is a new lesson I learned. Coming while talking about chronic conjunctivitis, the moment you see this cornea photo, who please name it. What is it? Like, what are these? Patterned abrasions. So the moment you see patterned abrasions, you are rest assured there is a foreign body somewhere there inside that eye. Just because you don't see it doesn't mean it's not there. You evert the lid of this patient. Can you see it? You can't, right? It will be exactly this difficult in the slit lamp also. So how will you check? What is one way to check? You're not really able to see it in your diffuse illumination. Is there any way to check? I want to confirm, does this patient have caterpillar hair or not? Very simple clinical thing we do every day. You saw this, at the same time you evert. The stain will pool around the hair. It might be just the very tip of the hair that is exposed. So using the fluorescent stain can help you identify these difficult or more deeply buried caterpillar hair. And the inflammation will continue until every last one of the hair is removed. So just because you found one hair, you cannot be happy. Patient will come back again and again and again until we remove every last hair, right? So now the technical term for this hair is setae. They're basically bristle-like structures on the caterpillar. They're actually sensory organs. And they also will let go of them as a defense mechanism, which is why there will be hundreds and thousands of them inside the eye. And until we remove every last one of them, there will be chronic inflammation in these patients, right? Talking about foreign bodies, this is another very common picture we see every day.
Form of immunology. You should not miss out Stephen Johnson, which is very common.
Stephen Johnson, right? In the VINTI.
Right.
Okay, so steel worker, welders not using protection present like this with iron foreign body. Will they always have a rustring? What is the mechanism of this rustring? Is every iron piece that touches the cornea rusted? No. So what happens is the tears interact with the iron in the particle, and that is how the rustring forms. It takes about 3 hours for this rustring to form. So not necessarily it will be there in every iron particle. If it presents very early, it may not be there. So how would you go about removing this? We removed the top part of it. This was left behind. Can we send the patient home now? The DNBs. We can't. So what will you do now? You will still scrape until every last bit of that brown stuff is gone, right? That is how foreign bodies must be maximally removed. And what will you use to remove these foreign bodies? No, but in your OPD, it's not available. We use a 26 gauge needle in our hospital. So you take a needle, you note where the bevel is, then you bend it such that the bevel faces us, right? Such that the bevel faces you, and then you have a very convenient dissecting device for you to very carefully remove the foreign body, and you can very easily avoid perforating the cornea because your needle is bent this way and not pointing directly at it. So make it a point to bend your needle, right? So these are some other foreign bodies which we have dealt with in our department. This was another steel worker with history of trauma to the eye with the steel particle. It went through and touched the iris, and we removed it in the OT. He is doing well. This was a very interesting case. A young man presented with shrimp tail embedded in his cornea. And here we can see this inflammatory hypopyon here. It was removed in the OTs. This was the shrimp tail, and he's doing well post-op. So there will be some situations when the foreign body will have to go to the OT. What are they? I can still remove if it is superficial in the OPD. Sorry? The moment your DM is breached, when you remove, you have a risk of your AC plaque. So it may be better to take it to the OT and remove, right? Fourth case, 7-year-old young boy, history of eye rubbing on and off since 3 years. Now he is complaining of an increase in redness in right eye with a ropey discharge since 1 week. And he gave us a bottle of olopatadine in the OPD and said, what do I do now? His mother was asking. So this is what it was looking like. Someone please describe the findings. Okay. Why are you missing the elephant in the room? The limbal hyperplasia, right? Question for chocolate. What is in a Horner spot? Plus, I'll give you half a chocolate. Eosinophil plus cellular debris will collect, and do you have eosinophil plus debris collected will produce these Horner spots. And at this point, I'd like to ask the panelists, what are the common immunomodulators we use in the OPD? At one point, do you start them in the treatment of the patient? It's not in the right one.
Okay, usually topical rhododendron started for about in tapering dose of 40 to 1. And along with that, which is actually we start immunomodulators like cyclosporin, which are basically immunomodulators, which is steroid therapy. So by the time drugs like cyclosporin take around 2 weeks to 1 month to act. So till that time we start the fluorotherapies. So usually it's continued for around 3 to 4 months. That is cyclosporin. So in that you can go up even to 1 to 2 years.
Right. So the most important point about using an immunomodulator is as a steroid sparing agent. And because the onset of action takes about 10 days to 2 weeks, it cannot act as an agent to abort the attack or abort an active attack, acute attack. And we have to use steroids to abort the acute attack and then use immunomodulators to maintain and keep the patient off steroids, right? Next patient, 4-year-old male, young boy, known case of allergic conjunctivitis. Is on treatment with us for a long time. Increase in the redness and itching in his right eye since 10 days. And he's saying, no, I did not have any trauma. Spotter. I everted the lid and got this. So now we have a clinically, we can almost definitely say that this is a shield ulcer. Question for chocolate. Mechanism of shield ulcer. Because of the papillae. Mechanically, because of the cobblestone papillae. No. So there's a toxic theory or an inflammatory theory wherein the inflammatory modulators also play a role in the ulcer formation. One chocolate. Grades of shield ulcer. Coming to the grades of shield ulcer, it's very simple. It starts with some SPKs. It starts with some unhealthy loose epithelium, which then become SPKs, which then become a macro erosion, which then become an ulcer. At this point, there is no infiltrate and the base is still transparent, right? So this is called a grade 1 shield ulcer. Then inflammatory debris start collecting inside this ulcer. Then it becomes grade 2. When it comes to the brim, it is grade 3. When it becomes a plaque, it is grade 4. Now you would ask me why I am boring you with this theory. This very same boy, he came with unhealthy epithelium 3 weeks prior to that presentation. Then he developed SPKs and then he got a shield ulcer. So these are patterns we need to recognize and keep in mind, right? How do you treat a shield ulcer? Very simple, 2 lines. Conservative management, surgical management. This is just for the exam. Conservative management, surgical management. Conservative management with? Loudly, please. Somebody said it. Steroids and under antibiotic cover with lubricants. What is the indication for surgery? What is a surgery? Surgery is simply a debridement. We have to do the surgical debridement of shield ulcers beyond grade 2. Just medical management will not be enough. It will prolong for months and months. Simple surgical debridement provides dramatic improvement in this situation. So this is just for the exam's sake. Remember, there's a surgical management and a conservative management, right? Next case, 39-year-old male, left eye redness since 1 week, recurrent attacks in the left eye since the last 1 year. Can you see it? You can see the dendrite now very clearly. I zoom in. We can see the terminal bulbs. Okay. Question for chocolate, mechanism of terminal bulbs. The answer is very simple. The herpes virus proliferates through a lytic mechanism. It enters the cell first, the epithelium, it proliferates there, it breaks out of the cell. Every time it breaks out, that epithelium sloughs off. So, and as it jumps from cell, it becomes a dendrite like this. And its advancing edge will be edematous. Those cytopathic cells would be there, which will make the bulb. And the path that it leaves behind would be sloughed off epithelium, which will stain positive with fluorescein. So no chocolate. Similarly, 65-year-old male, redness and watering since 15 days, went to the medical shop, used festive D, and he has similar such episodes in the last 1 year, 2 times. Spot diagnosis. Geographic ulcer, okay. The load of herpes infection in the entire world is extremely high. It is a public health issue. Up to 1/3 of the population is infected with HSV. And coming to just viral keratitis, I am going to make a flow chart. I will finish viral keratitis in this one slide, right? So, question for chocolate. Primary herpes virus infection. What are the manifestations? Yes, chocolate. Would it be, what age would the patient usually be? It would be a child. Nowadays, adolescents. One more. Only that much? Blepharitis. What in the lid, we would see those typical vesicles. Generally, the other
form is not common.
and you are the most common
Primary presentations in a child.
secondary mostly is in an adult,
Right?
right?
So most of the patients, the adults,
Yeah. It's echoing. Okay. Coming to the secondary form, most of the patients we see in our OPD are having secondary viral keratitis, right? So they've already had a primary infection at some point in their life. What are the types? Epithelial, stromal, endothelial, metaherpetic. Epithelium, SPKs, dendrite, geographic. Stromal, no. Necrotizing, non-necrotizing, right? Endothelial, disciform, linear, diffuse. Question for chocolate, what is meta? Chocolate for ma'am. So a metaherpetic viral keratitis would mean anything beyond, right? Meta-analysis is the analysis of an analysis. So metaherpetic is the consequence of herpes infection, wherein wherever this lesion goes, it leaves behind in its wake corneal anesthesia. And there will be basement membrane scarring also. So even if there is reepithelialization, it will not stick. It will not stick, and so it will lead to persistent epithelial defects or neurotrophic keratitis in this situation, neurotrophic keratitis. Differentiating feature between geographic and neurotrophic. Question for chocolate. Okay, okay. Geographic. Geographic looks geographic and it has a classic progression, whereas neurotrophic will be very long term. chocolate. I think. At this point, I would like to ask the panelists for very short heads recommendations, please.
There are some type of recommendations. Recommendation. Only use antivirals, acyclovir and ganciclovir is the popular one. Acyclovir, people in iron for epithelial involvement is 5 times per day, and ganciclovir, 0.15% jet, that is 5 times per day for because epithelial needles, and then 3 times per day for 7 days. That is the recommendation.
Topical.
And for the anti-oral form of antiviral, in epithelial form, according to the head, in dendritic form, it is 40 milligrams, 400 milligrams, 3 to 5 times a day for 7 to 10 days. And in geographic, it is 800 times, 800 milligrams, 5 times a day for 2 to 3 weeks. But we follow a slightly modified version in our clinics. We use it around 400 milligrams 5 times per day. And we see it for around 2 to 3 weeks. After the patient is improving, we gradually taper it. And according to the heads, the stromal and the epithelial keratitis, if there is without an ulcer formation, it is 400 milligrams daily, according to heads. And if there is an ulcer, it is 800 milligrams 3 to 5 times per day for 7 to 10 days. In endothelitis, again, it is 400 milligrams 3 to 5 times per day for 2 to 3 weeks. And I would like to talk about the prophylaxis, how it is followed. If it is an initial epithelial form of HSV and it is the first encounter, there is usually no prophylaxis given. But if there is a recurrence of the epithelial keratitis, there is a prophylaxis for 1 week. And if there is HSV of the stromal type, in an uncomplicated case where there is no scarring and no vascularization, then the prophylaxis is given for 1 year. But if it is a complicated case where there is scarring as well as vascularization, then the prophylaxis can be continued for 2 weeks to indefinite. And even in a chronic case, again it is for 2 years to around indefinite. So that is the dosage of that is BD for continue. And as well as in cases like PKP induced post PKP due to viral, again it is 2 years prophylaxis or to indefinite. And as well as PPK cases, again it's the same thing for 1 year minutes of prophylaxis needs to be done.
So the underlying point here is that most of the infections we see in adults happen to be secondary infections. So what that means is the patient already has the virus in his trigeminal ganglia. So in any of these secondary forms, oral acyclovir or oral antivirals will play some role. So that is the logic behind that. Epithelial keratitis.
Then we have to do a prophylaxis for 1 year. Yes, ma'am. According to the heads. Yes, ma'am. Yes, ma'am. Ma'am, heads. 2, ma'am. Come here. Come here. 1 year.
Coming to the next set of cases, 51-year-old male, left eye, redness, pain, photophobia, 10 days duration. Provisional diagnosis, please. Marginal, Vipin ki chocolate. Now tell me why. No, why do you think that this is marginal keratitis and not any other infiltrate? We have to look at the eyelid, but it is not in 100% of cases associated with blepharitis. One more chocolate for Manjot. There is a clear area here. See, these are the infiltrates, and this is the clear area. There's a clear area between the ulcer and the limbus. It is a lucid. Okay. Alcohol. So there is lucid interval. Second pathognomonic feature. Ma'am, give all the chocolates. So pathognomonic features: 1, lucid interval; 2, parallel to limbus. That is my next case. So marginal keratitis is a hypersensitivity reaction. Question for chocolate type. It is type 3. This is type 3. It is antigen antibody complexes which are deposited as a result of chronic presence of the organism locally, and then neutrophils will go to attack this organism in the cornea, causing these sterile infiltrates. So we treat with topical steroids and antibiotics, but we have to be careful to make sure that there is no secondary infection or that it is not some other microbial keratitis which is presenting just peripherally. So we have to be careful when we start the steroids. Again,
associated with dermatitis at the 10 o'clock marginal keratitis will be associated with blepharitis, and the infiltrates will be classically located sometimes at the junction where it touches the eyelid, like 10 o'clock, 2 o'clock.
Exactly where the lid touches the cornea, these infiltrates may present. Most of ophthalmology, what we see is educated guesses. So we can take educated guesses, we can operate with caution. But this was a very classical case. We started with steroids and the patient dramatically improved. Similarly, we have some other cases of marginal keratitis here with which is also taking up a leash of blood vessels. Now, this was actually a case of viral marginal keratitis. Next case, related to marginal keratitis, young male, 24 years, redness in the right eye since 4 days. There is some history of trivial trauma just prior to his presentation. There's no history of fever, no history of joint pains. Differential diagnosis. Possible, but it's only 4 days. Scleral abscess is a possibility, but history of trauma is there. Would it be so compact and localized? So generally, it comes in the tarsal. Okay. We investigated him. His CBC, his investigations turned out to be normal. His MANDU was negative. Turns out it was a case of conjunctival Phlycten. It was a Phlycten. I'm coming up, ma'am. We have more cases, so it's not the only case. Yeah, this was a little bit atypical. It was actually marching on to the cornea. We can see here. I'm not able to zoom. You can see that the marching into the cornea has started. Phlycten is a delayed hypersensitivity reaction type 4. Marginal keratitis type 3, Phlycten type 4. We can consider Phlycten as a more of a expanded form of marginal keratitis. Phlycten is a unit of inflammation. If you take a Phlycten, put it under the scope, we would see WBCs. We would see a bunch of different types of chronic granulomatous cells. And in my MBBS, I used to mug Phlycten is the immunologic manifestation of TB. Immunologic manifestation of TB. So in India, especially in developing countries, Mantu or quantiferon gold is a mandatory investigation in these patients. They're generally very young patients, generally they're children, right? But in developing countries wherein TB is not so common, it can be associated with, just like marginal keratitis, it can be associated with staphylococcus. And worm infestations, yes. So this was a quote in one of the journals I went through, and I found it very pertinent. Phlyctenulosis in a child usually is an indication that an active case of TB is there somewhere in his environment. So that is what happened in this patient. 4-year-old boy, 15 days history of redness, presented with bilateral Phlycten, classical picture of white mass present in a background of conjunctival congestion. It was a bilateral case. His mother had history of fever with cough for the last 2 weeks. We had sent her to the pulmonologist for investigations. We treated him with topical steroids and we sent him also. But generally, this is an immunologic reaction, so we don't expect him to have the disease. So he did well after starting on topical steroids. There are 2 forms of Phlycten in the eye. They can be conjunctival or corneal. Corneal is quite rare. What we see here is a corneal Phlycten, which brings up a leash of blood vessels with it. It is typically described as a marching lesion. And it is described as a fascicular ulcer with a broad base at the limbus, tapering towards the center. So this is many a times we have seen referrals to the cornea department calling this as nodular episcleritis. It's generally very uncommon in a child. First differential diagnosis in your mind should be Phlycten. Children and adolescents. Children and adolescents, according to yes, in girls it is more common. Yes. We have come towards the last set of cases. Old 78-year-old female, left eye redness since 2 weeks. She's fairly comfortable, foreign body sensation, no history of trauma, spot diagnosis. Bright red appearance, comfortable patient, 2 weeks duration. This is a case of episcleritis. Question for chocolate, when do you want to investigate episcleritis? In recurrence, Manjot gets a chocolate. When you get recurrent non-resolving cases, we may have to investigate episcleritis, but only up to 30% of cases with episcleritis. Only up to 30% of cases with episcleritis are associated with systemic disease. So it's not a very common practice to investigate systemically an episcleritis patient. In the first episode, generally, we can just treat symptomatically. Next case of 51-year-old female, redness on and off bilaterally since 2 years, severe ocular and facial pain. She has repeated attacks over and now she's having an exacerbation since the last 1 week. It's a case of nodular scleritis, and we can pay attention to this part, wherein there is some amount of corneal involvement also. So this was a case of sclerokeratitis. The other eye cornea had also had tongue-shaped scars. Unfortunately, we don't have those pictures. We had sent her for investigations. We lost her for follow-up. Similarly, 45-year-old male, good vision bilaterally, but very symptomatic, very painful, not letting us touch his eye. He has no history of fever or trauma in the past. Recently, it's a classic violaceous appearance of scleritis is present in this patient. Question for chocolate: differentiate between scleritis and episcleritis. 1%. Besides that, pain is a very important differentiating feature. That is, if we want to differentiate nodular scleritis and episcleritis, ma'am, there will be a grade, ma'am. Okay. Yes, tell me about the color. Violaceous is scleritis, bright red is episcleritis. So comfortable patient, bright red, that would generally be episcleritis. But violaceous appearance not reducing when you use phenylephrine drops. Yes, ma'am. If it is nodular, it would be like that. Yes. This patient did not present like that. The ones I have here are localized. We investigated this male patient. He was positive for his quantiferon gold for TB was positive. Rest of his immunological investigations were negative. We have sent him for various evaluations and he's yet to return to us. Last case, 23-year-old female. She is a doctor. She has his recurrent history of episodes of redness in both eyes. She's suffering with this on and off since 1 year. She's quit studying for her exams because she's in so much pain. But we saw her in remission. This is picture of the right and the left eye. In the left eye, we can see generally this is that is a differential diagnosis, but this was bilateral. This was bilateral and patient was extensively investigated rheumatologically. She was HLA-B27 positive. Mandu was positive but non-specific. She was put on oral immunomodulators like methotrexate and also on injection of monoclonal antibodies. Now she's in remission. She's doing well. She has good vision. She has a very strong family history wherein her mother, her grandmother's sisters are all HLA-B27 positive. So the main point here is that scleritis is associated with a very strong systemic history, and up to 66% of scleritis patients can be associated with having some systemic disease, especially if it is of the necrotizing type. Question for chocolate: classify scleritis. Anterior and posterior. Anterior is divided into nodular, diffuse, and necrotizing. Necrotizing is divided into. Oh my God. With inflammation and without inflammation. Without inflammation is called. What is the underlying pathology in necrotizing scleritis? Not Anuradha. Chocolate, please. There will be inflammatory vaso-occlusion. Occlusion of the blood vessel leads to loss of blood supply in that area, which will lead to necrosis. So when you see a necrotizing scleritis, you know that there is occlusive vasculitis. And if there is occlusive vasculitis in the eye, there is occlusive vasculitis everywhere else also. So especially if you see a necrotizing type of scleritis, 66 to 80% of the patients are associated with systemic disease. By the time it presents in the eye, it is already very late and he needs urgent systemic treatment. So referral to the rheumatologist and a combined approach with the rheumatologist and the ophthalmologist is very much necessary in scleritis. Ma'am, this we got in the in state of remission, ma'am. She is not active right now. Sclerokeratitis. Yes, ma'am. No, ma'am, she is doing better now. She came for a review. We just wanted to.
Ma'am, it's actually bilateral sclerokeratitis. She was a medical student, so that's why I could take a picture when it was very active. When scleritis was active. Yes.
No, ma'am. Snack time. Thank you. Yeah, who got the maximum chocolates? Yes. No, we have to count.